Anyway, thanks everybody for joining us in another DENTACHAT today. We've been trying to we started doing this over the lockdowns and COVID with different topics, and we just keep doing it, offering a little bit of knowledge and learning, not only for dentistry, but, around owning a business, and obviously dental practice, marketing, etc. But today we have Dr. Pat from across the ditch. From a lot warmer than what we are today. It's been very windy and wet, and it's just one of those days that you don't want to be a rep, but oh well. A little bit of hail, a little bit of rain and everything. But we're going to talk about the Conserve Endodontic, and obviously Dr. Patrick is endodontist in Sunshine Coast in Queensland. But has a great career, from doing implants, and especially implants and endodontics. That's what you normally do now, day to day, Patrick. But he's been a dentist for over 20 years.
Yeah, something like that. Yeah.
I feel like that. Still want to disclose the year you graduate. But it's been involved in different associations and colleges as well. But Patrick, thank you so much for joining us. We're really looking forward to, see what can we to be excited about the endodontic world. So yeah, thank you for coming and joining us on this side of the world.
All right, thanks for the invitation too. Yeah, look, what I want to talk about today is something that we've become pretty, I guess, passionate about sort of 10 to 15 years ago, but now is really, I think, starting to become mainstream and accepted as the standard. I'll just start my lecture so that you can tell me if this is all presenting properly. So can you see the lecture now?
No, we can't.
You can't. Okay. All right. So I have to share my screen, right?
That's correct. Yeah. So if you were doing shopping on your web, there you go. Got it.
Okay. So if I just press play on that.
Yeah.
We're good?
Perfect.
Yep.
Perfect. Thank you. Yeah. Got it.
Okay. All right. Yeah, so it's really become fairly mainstream now, I think. And I often get the question from dentists in terms of how they can improve the conservative aspect of their endodontics. So I'm going to talk about that today, some practical things that every dentist should be doing in terms of the way they approach this. So this is where I live. This is the Sunshine Coast, Point Cartwright, and my house is just a little bit further down along the point, and to the right is Mooloolaba, beautiful part of the world. I think we have direct flights to Auckland over winter, at least, because we have a pretty mild winter here. Great place to come and visit. Come and say hello anytime. This slide just shows some of the progression. So at some point in 2022, I was giving this lecture, and I just picked out the very last lower right molar that I had treated. So that's what that case is. And you can see a case from 2009 that I was quite happy with at the time. This was a case that I did in Shanghai when I was living over there. But this case, you can see there's quite a number of differences in the way these cases are approached. The case on the left, there was a lot of focus on ensuring there was a nice, thick, dense root filling that looked good on the X-ray. In hindsight, when I look at this, I think there's probably a bit more tooth structure's been removed than necessary. There's not a restoration in the tooth. There's only a temporary restoration. And I certainly wonder whether there might have been a little bit of straightening of the canal at the apex. But that worked well, and that was the sort of thing that we looked at and thought, okay, that's been done thoroughly. Around the same time, so 2010, we had David Clark and John Cartamy release a narrative. So just it was an article, no research, just their thoughts on how we should be performing access. And they talked about this concept of directed dentine conservation. And this is a screenshot from that paper, and we can see they basically, taken an X-ray and drawn over the top of it, and sort of suggested what the line in black is their idea of how access should occur. So compared to what access is actually being performed. And also around the same time, there was this discussion. This is in the British Dental Journal, and it was a paper looking at ferrule, or the restorative aspects of crown and bridge. So ferrule, when I became a dentist and I was doing crowns, I would think of ferrule in terms of height. But really, they're saying, there's three aspects of this. There is height, and there's also the angle of the ferrule. And there's also the width of the ferrule. So we can see those blue arrows where the width is highlighted. And there's two things that, they say that's quite important as well, not just the height of the ferrule. The height of the ferrule will add retention to your crown preps. But in terms of resistance form, in terms of the tooth resisting fracture, then the width of the ferrule is quite important as well. And there's two ways we affect the width, and one is cutting it from the outside and the other is cutting it from the inside, removing dentine internally or externally. Clark and Cartamy, they talked about how different parts of the tooth have different values. And so you can see there, they say that the tissue type, the PCD, so that's the pericervical dentine, that's tooth structure 2 to 3 millimeters above and below the CEJ. They say that's very high value. Even undermined dentine is valuable. And if we sort of go down the prep, we can see tertiary dentine, not particularly valuable. And unsupported enamel, for example, is not particularly valuable as well. So they're saying that, not all tooth structure is the same. All of our studies that look at how strong teeth are, and especially when it comes to endodontic access, so studies that look at how strong teeth are and how much flexure there is in the tooth structure, basically say the same thing. And they say that in an intact tooth, simply performing an endodontic access doesn't really reduce the strength of the tooth that much. But when you lose a marginal ridge through, restoration, or probably, it hasn't been studied as much, but probably even with a crack, if we have a crack, then we get significant increases in flexure of the cusps. They also do show that restoring the cusps, like overlying the cusp, giving some sort of cuspal coverage, will help bring some of that strength and some of that flexibility back as well. All of the studies that we have that look at how root-filled teeth fail all sort of show us that it's a very similar pattern of failure of root-filled teeth, and that is that most of them fail by breaking. So here's two of the most commonly quoted studies. So we can see that there's some difference in there for sure. So 9% endodontic failures versus 34, and perio failures about a third down to about a tenth of the teeth. But the majority of teeth that are failing endodontically are failing because they break. So prosthetic failures there means that the tooth structure breaks or the restoration breaks and the tooth is not restorable anymore. And I think as endodontists, in endodontic practice, we maybe get a little bit of a warped view of how root-filled teeth fail, because if a root-filled tooth fails and it's unrestorable, if it breaks and it's unrestorable, we generally don't see it in practice because it gets extracted and it gets replaced. But what we do see is the endodontic failures. And so it may be, we probably have a little bit of a biased view of how these teeth fail, and probably put more emphasis on the endodontic failures than there is in general practice. So this was a tooth I treated back in 2002, and I saw it again in maybe 2014 or something like that, 2015. I did that case while I was a postgrad and presented. It was referred back to me just coincidentally. And there was a pocket there. When we raised a flap, we can see that there's a crack up through the root. So this is a common method of failure. When we, this is Rick Schwartz. He's a endodontist in the US, and he was a restorative dentist for a long time. I don't know exactly how long, but it was, maybe 20 years. He'd written textbooks on restorative dentistry, and then he became an endodontist. So he went back to uni and became an endodontist. In his practice, he did a 10-year recall. So 100 sequential patients, went back and did everything he could to get the recall data on those. And to his surprise, he found out that 26 of those 100 teeth that were treated had been extracted. Out of those, 6 were endodontic failures, pure endodontic failures, and 2 of those were questionable as well. So the surprise there was that it was a little bit higher than he expected, but also surprising that the vast majority of those teeth failed restoratively. This concept of patient-centered outcomes that keeps coming up, it's something that I think is gaining a lot more emphasis in dentistry. It's been around in medicine for a long time. In maybe 3 years ago, maybe 2 years ago, just after COVID, the ITI meeting was meant to be in Singapore, and that's the implant meeting. And it was the sole topic that was to be covered was patient-centered outcomes in implant dentistry. So it's definitely receiving a little bit more focus. And basically what all the organizations that look at patient-centered outcomes focus on is they want to focus on outcomes that matter to patients. And so that's things like cost, longevity, and quality of life. And it specifically not rejects, but doesn't place value on things that are not those. So anything that's measured in a study that is not one of those things, they say, well, that's good and interesting, but if the surrogate that's measured doesn't match the actual outcome and hasn't been proved to be tied very closely to the outcome, then we have to be careful that we place value on it. So, example that they give is that if you have hypertension, you will generally, on average, die earlier. And if there are drugs that will lower your blood pressure, but some of those drugs in their clinical studies lowered the blood pressure of the people taking them, but they still died earlier. So they actually, had the opposite. So they had the surrogate, the thing that was being measured, their blood pressure dropped, but the outcome that mattered, longevity, moved in the different direction. Now, the reason we're focusing on this is because when I showed that case from 2009, where I had the thick white lines on the X-ray, that was the outcome that seemed to matter at the time. That's what we thought mattered. So getting radiolucent lines to the apex. But maybe that isn't the thing that makes these teeth last the longest. And maybe it's not as important as we think in terms of pain and quality of life as well. All right, so this is a photo from a textbook, traditional access. It shows quite a wide access. And the next thing that had to be done in this case was to remove the triangle of dentine to give straight line access. And going back to that concept of the ferrule, when we remove internal dentine and then we prepare this tooth for a crown, we can see that we are affecting the width of the ferrule. This is another another image from a textbook, so we can see the straight line access there. This is from the Pro Taper training videos, and we can see the straight line access here. Now, there was a very good reason that we needed straight line access in the past at that point, and that's because the rotary files, although the nickel titanium was flexible, it still had limits that don't exist today with the sort of files that we have available. And what it meant was that we had to have straight line access. We wanted straight line access in order to limit how much the files had to work and limit how much they had to bend, and therefore reduce the separation from the instruments. So we actually got these instruments that were new and made life easier for us, but then we altered our technique to be more aggressive in the way that we performed endodontics to protect the instrument that we had. And it sort of flowed on from that a whole lot of reasons then came up why we should be being aggressive in these cases. And there was a lot of research that if you put it together, you could easily come to the conclusion that we should be drilling these big holes and removing a lot of dentine in order to be successful. These are from the, so you see there, that's from Dentsply Sirona. So this is the Pro Taper Next videos, training videos. We can see the removal of tooth structure there. This is from Dentsply Sirona. So that's the training videos there. And we can see that there are definitely thick white lines, but in these cases, there's fairly generous endodontic accesses. And that's, again, what needs to be done with particular instruments that are less flexible and where the instrument needs to be protected. There's a little bit of research that came out, and when this concept became popular, so we can see on the right there, this is some research that was done in 2016, and generally what would happen was a bunch of teeth, we would get a bunch of teeth, often intact teeth, but not always, and then a hole would be drilled in them, and then they'd be put in something like an instrom machine. And that machine is simply something that gets the tooth and puts force on the tooth, increases the force until the tooth breaks. And that level of force would be measured. Usually it was something like 10 teeth in each group, and then the data from that would be, a p-value would be selected, and it would be, data would be put into some software and run through the software, and then it would spit out whether it was significant or non-significant, which is fine. The problem we had was then statements were being made based on that data to the effect of, it doesn't matter if you cut a big access or cut a small access in the tooth, it doesn't affect the strength of the tooth. And it's probably a good, 6 or 7 or 8 years now that the American Association or Society of Statistics has told us to please stop making clinical statements from data that uses a p-value to determine whether something is statistically significant or non-significant, because it certainly doesn't do that, and it can't do that. If we want to work out whether being more aggressive or more conservative leads to a tooth lasting longer, we have to have quite a complex design study. We have to have a clinical study where a tooth that needs endodontic treatment is randomized to either being aggressive or being conservative, and then that tooth and the person needs to be watched over time, probably 10, 15, 20 years, and we need to see which method of treatment would provide the best patient-centered outcomes. So which one would cost the least over time, which one would result in the most function and cost and aesthetics, and work out which one was superior. And we're not going to do that study, and it's impractical to suggest that that's going to be done in dentistry anyway. In medicine, they do some extraordinary studies like that, but it's probably not going to happen in dentistry. The other thing that I found with most of these studies is if we look at what's being taught in terms of access, so like on the left, and we look at the research that was done, in that research on the right, the black dotted line is what they suggested was a traditional access, the large access. That was the large access. And the little hole in the tooth is what they said was the contracted access. And, you know, when you look at Clark and Cartamy's work, certainly their suggestion or their commentary was that we should be reducing the size and the shape of our accesses down to something like what's on the left. Whereas the research was saying that was already the traditional access and comparing that to a tiny little hole drilled in the tooth. And not many people do that. Very few people can work through a little hole like that. There's probably some people around who can, but the majority of us don't work through that. So, you know, I don't know that a bit of research that looks at this and is, you know, I don't think it's really comparing apples with apples. I think this sort of comparison is more what was being recommended by Clark and Cartamy. So moving from the type of straight line access on the left to the what might be called orifice directed access on the right. And the type of access on the right, where we're not removing so much of the triangle of dentine and providing straight line access, is now made possible because we have instruments that are far more flexible and far more resistant to cyclic fatigue, and instruments that can be made in a much more narrow profile to be more conservative. So while the access on the left is safer for your instrument, the access on the right is safer for the tooth, and it means that we would need to use an instrument that is much more flexible and conservative. So if you're still using instruments that, you know, older style instruments that are less flexible, you still need to be doing the access on the right. You shouldn't be trying to move towards the access, the access on the left. You shouldn't be trying to get more conservative because the instruments aren't designed for it. So in terms of patient-centered outcomes, these are the things that we think matter in terms of longevity. We want to maintain as much dentine as possible. We want to restore the tooth immediately. That's something that we think, and there's some limited clinical research to support that. Something we think is very important in the tooth. Actually, the outcome of the endodontics is putting some sort of restoration, permanent restoration in the tooth as soon as possible after it's obturated. Obviously, cuspal coverage to protect against occlusal forces and control of occlusal forces. Ultimately, you know, with root-filled teeth, with them failing due to fracture, most commonly, occlusal forces are what it all comes down to. If you're not biting on the tooth, then it's unlikely to fracture. If you have someone, if it's a lower 7 and has a crack in it and the patient bruxes, then it's at much higher risk of fracture. In terms of pain control, all the things that we think about in endodontics, so making sure we treat all the canals and we treat them to appropriate length, and we get enough microorganism control so that the tooth becomes asymptomatic and functional, and probably restoration as well, getting the tooth restored so that it's not leaking or breaking. So this concept of orifice directed access, this is simply removing tooth structure that needs to be removed in order to complete the endodontic treatment, to improve vision and light. And the concept says that this occlusal aspect of the tooth, this bit of the tooth is replaceable. So this, in the vast majority, almost all of the posterior teeth that we treat, they're going to receive some sort of cuspal coverage restoration, whether it be a crown or a direct composite or an onlay, bonded onlay, something like that, but we're going to remove this bit of tooth. So this bit of tooth is replaceable, and in fact should be replaced. So that's something that we don't place a lot of value on, tooth in this zone. We believe that this bit of the tooth, the dentine and the couple of millimeters of dentine below the CEJ are important for the strength of the tooth. So again, that comes into the concept of the ferrule, the width of ferrule that we were talking about, but also how much root structure is removed in the through endodontic procedures. So, and that ultimately comes down to the flare and size of our instruments, and that this part of the tooth is important for strength, but less important for strength. Obviously, it's further down into the roots and it's buffeted by the periodontal ligament. There's concept of convenience access, and that is when tooth structure that's already missing is preferentially removed, or that is already limited is preferentially removed to allow endodontic treatment to be completed and leaving as much tooth structure in those important areas, in those valuable areas. So we might have something like this. So again, the low value, the important, more important, and the less important areas are protected. So for example, if we look at this photo from the textbook that's talking about thickness of ferrule, this, in my mind, if we're going to improve our access here, for example, you're not going to work through the little hole that is the image on the right. We can remove the restorative material because it has 0 value, and we can remove the tertiary dentine and dramatically improve our vision and access into a tooth like this. So this is the important bit. Obviously, with anything like this, there is a learning curve. So as you start to become a little bit more conservative, it's something you should take baby steps in. It obviously takes time. You know, there's this concept of deliberate practice, saying that, you know, it might take you 10 years to become adequate at a procedure, and that we need to be practicing it. So we shouldn't jump straight into being very conservative, and it's probably the biggest mistake that we see people make is trying to be too conservative too early, and even too conservative, more conservative than they should be, in line with the concepts that we talk about. So I was sent this image by a dentist who said they were trying to be conservative in their access in this upper premolar, and found they weren't as conservative as they'd like to be. So they're asking for tips. And an upper premolar that's lost a marginal ridge is one tooth that is really, it's almost crippled by endodontic treatment. You know, it's especially if it's lost a marginal ridge, because there's so little tooth structure and it's so easy to go off track and remove more tooth structure. And by the time you prepare these for a crown or even an onlay, there's often not a lot of that valuable dentine left. So it's a tooth that we should be particularly careful with our access. And a few things jump out at me with this. So this is a tooth we're going to perform endodontic treatment on, and even in an emergency situation, so this was a tooth that was sort of squeezed in as an emergency, we're still going to isolate multiple teeth here. And there's a very good reason for that. We'll get into it. But you can see, just even with this, just even isolating multiple teeth, being able to see the outline of the tooth, you can see that you're going to already be able to be more accurate and more particular with your access if you can see the outside of the tooth, compared to just isolating one tooth and only being able to see that tooth. All right, so this, one of the important aspects of this comes down to Krasner and Rankow's law of centrality, and that is that at the CEJ, at the level of the CEJ, the pulp chamber will approximate the external root surface. Okay, so shape of the roots will be approximated, the shape of the pulp chamber will be an approximation of the shape of the roots. And so in order to use this, we need to be able to see the outside surface of the tooth. So here's a tooth that is not quite down at gum level. It's been prepared for a crown before we treated it endodontically, but you get some idea of what we're talking about there, we can see that the outline of the tooth is mimicked by the pulp chamber, the closer you get to the CEJ level. So we want to be able to see the outline of the tooth at the gingival level at least, so that we can better approximate where the pulp chamber is. Just practically in terms of isolating multiple teeth too, for example, here, if we have a lower 7, we've got a mesial caries, we've got an occlusal restoration. If we think about once our access is done, once our root canal treatment is complete and we prepare the tooth for restoration, the maximum amount of tooth structure that we can have remaining, it looks something like this. And so all of this, everything that is missing here should go immediately. This should be the first step that we do, is remove any sort of tooth structure that we're not going to be utilizing long-term for the tooth. And therefore, it's beneficial in that case to isolate multiple teeth, at least 2 teeth, but preferably 3 teeth, so that we can see, we can restore this tooth properly, and very importantly, so that we can assess the tooth properly, because we can't assess this tooth properly until we've removed all of the restoration. A question that I often get in terms of this is if we're going to, if we want to isolate multiple teeth, but we have emergency cases, I'll show you how we do this practically. So in this case, we've got an upper 6 with a mesial restoration that we're going to remove. So we place the clamp on, and then the DA flosses through, whether you do individual teeth or a slot type preparation like we've got there. I don't think matters. The slots are a little bit quicker if you're in a hurry, and can be isolated well with things like Oraseal. So dam goes over the top, dentist flosses, and you can see there that when I went to look, the rubber dam's not quite around there, so we just adjust that, get your fingers down around it, make sure it's sitting tightly around the dam, and you can just do that with your fingers most of the time. And then we use Oraseal to seal along the dam. So this is a split dam type technique, and that's cotton pellet soaked in EndoSure to clean the surface of the tooth and also pat down the Oraseal, and then we're going to floss through distally as well. So we get very good isolation very quickly, as well as being able to see the teeth. An important aspect of this, I think, in terms of the assessment of the teeth, is that we need to be able to get into proximally in most teeth. A huge proportion of the posterior teeth that we treat endodontically have a crack in the mesial or the distal aspect of the tooth. And in those teeth, if we have a crack and we have a periodontal pocket, a narrow pocket adjacent to that crack, then that tooth has a very poor prognosis. And we can only probe interproximally if we were honestly able to get our probe into that area. And my experience is that you cannot do that with the contact closed. So you can't probe, if there's a cracked mesial on this premolar, you can't probe unless you remove that bit of tooth. Now, this was a case not that long ago. I saw, and it was a lunchtime emergency. So we got stuck in, we isolated it, and actually I'll get to this case, but it just showing this with lunchtime emergency. So we've isolated 3 teeth quickly. Again, if we're going to access this premolar, we can see how much more accurate we're going to be with multiple teeth isolated than with the individual tooth, the rubber dam just on that one tooth. But I'll get to that.
In this video,
we can see in this case, this is a crowned, rotated upper premolar, and we need to perform endodontic treatment. So this is a tooth probably with lower incisors. This is one of the teeth that is the most difficult to be accurate with our access on. And you can see that even though we don't need to isolate other teeth for any sort of restorative aspects, we're going to, we can only probe as much as we can. We're not going to remove the crown in this case. We're going to try to hold on to the crown. We could have just isolated that one tooth, but we still isolate multiple teeth in order to see the outer surface of the tooth. And what we're doing here, you can see we're accessing, we're using a long burr, we're zooming in just to look at the landmarks inside the tooth to help find our canals. But when we're drilling down, we're actually zooming out. We're not looking in the tooth, we're looking at the outer surface of the tooth. We're using a long burr because that long burr gets the head out of the way, but also gives us more of an indication of the angle of the drill. So if we go back to the start of this, we can see that we're zoomed out and we're looking at the angle of the drill, the angle of the burr, and we're comparing it to the angle of the tooth. So we're looking down at the gingival margin and we're almost just trying to sort of imagine where that drill is within the crown of the tooth, because you can't see into the tooth when you're drilling in there. And if you focus inside the tooth, then you're far more likely to go off track. In terms of the assessment of teeth, it's also far more beneficial to remove all of the tooth or the tooth that doesn't need to be there, and the restoration as well. So probably before we even get to that, the X-ray that is most valuable in determining the difficulty of a tooth endodontically is, I think, more the bite wing rather than the PA. So we can see a PA of this tooth here, and when we get the bite wing view, when we get the flatter view, we can see that the pulp chamber has receded. The vast majority of problems that I see just in terms of the teeth that are referred to me. So the teeth that are referred to me where a dentist has initiated treatment but hasn't been able to locate canals or prep the canals to length occur in teeth that have calcification of the pulp chamber. And that will either be the pulp chamber receding so that it's a low height pulp chamber, it's a short pulp chamber, or it's a pulp chamber that has pulp stones in it, calcifications in it. So obviously cone beam CT is very valuable in that sense. So the tooth on the left with that calcified pulp chamber, far more difficult case than the tooth on the right that has the large pulp chamber. Similar situation, we're looking at the height of the pulp chamber. Probably, I think the most important thing you can do, and either a very flat PA or a bite wing view is the one that's going to give you the most information about that, and also help plan your access. Here we go. So on the left, we're looking at the periapical. So we're looking at the whether the canals appear to be patent. We're looking at the angle of curvature of the canals, and that is not as big an issue now with the more modern instruments that we have because they're far more flexible. It's a far smaller issue than it was before because the instruments we have now are able to handle curvatures much, much better than our older instruments with much less chance of failure or separation. The bite wing view on the right helps us see that regardless of what's happening in the root, this is going to be a difficult case simply because of the calcification that's in there. In this tooth, I just want to show you this one. So this was a tooth that, here's the pre-op X-ray. We can see that there's not a very small, there's not a very high pulp chamber. A dentist had accessed this already. And when I got the tooth, we can see there's a big lucency and approximately there. We can see that the canals don't appear very patent. And when I went into the tooth, this is the pulp stone that came out of the palatal canal. And this is an additional problem with teeth that have pulp stones in the pulp chamber. They often have pulp stones down in the canals as well. And what that means is that as you try to work down the canals, you're having to fight all these little pulp stones. Very common in lower molars in the distal canals, especially canal where there's two canals or an hourglass shaped canal. If you have calcifications down in there, you just keep prepping and cleaning and prepping and cleaning, and especially with the microscope, you look down there and you see all these little calcifications still hanging around. You see it down in palatal canals a lot. It's definitely something to look out for. Just out of interest for this tooth, this did actually have, we can see loss of all the furcation bone, and it had a sinus tract, and it had probing, it had a deep narrow pocket, but we didn't actually see a crack. And so we dressed it with calcium hydroxide, and you can see that the pocket resolved and the sinus tract resolved. So this was a case of a sinus tract draining through the periodontal ligament. So I think in terms of assessing the teeth with cracks, if we have a visible crack and we have a pocket that associates that, then that has a very poor prognosis. But if we only have the radiographic bone loss, or we only have the periodontal probing, if there's no actual crack there, then that's a tooth that we should at least dress and see if it resolves. I'm not going to go too much longer, make sure there's some time for questions, but I wanted to just labour the point in terms of our ability to assess these teeth. If we follow an access technique where we remove any sort of coronal tooth structure, and we're going to be running some courses in New Zealand in early 2024 that will go right through all this technique, and hopefully get you to practice it before you come into the course. What it means is that we can properly assess these teeth. This is a tooth I showed before, emergency tooth at lunchtime. It's, painful tooth. I accessed it and I thought, there's just that restoration has been done recently by a good dentist. I know that it's bonded well. I might just leave a little bit there to help with isolation. I can see, there we go, we've gone in. I'm like, there's a little crack there, but it's not too bad. You can just see it there. And then I thought, I really should practice what I preach and take this restoration out. And sure enough, I removed the restoration, and there was a very deep probing defect adjacent to the crack, and I could see the crack much better. So you can't assess these teeth properly. And the narrative for your patient should be, we're going to remove all the restorations from this tooth. We're going to see if we can find the canals. We're going to have a look and see, check the structural integrity of the tooth through remaining tooth structure and presence of cracks. And then we'll be able to give you a better idea of the prognosis of this tooth. Because ultimately it's not till you find the canals, prep them to length, make sure you can prep them to length and assess the structural integrity of the tooth that you can give that prognosis. Professor Paul Abbott in his private practice did some research where he looked at, 50 or 100 teeth, sequential teeth, and he assessed for caries, cracks, and marginal leakage. And then he removed all the restorations and he reassessed for those things, caries, cracks, and marginal leakage. And he found that if he assessed before removal of the restoration, he missed about half of the caries, cracks, and marginal leakage. So you can't assess properly until you remove all the restoration. So this tooth now has if I didn't remove the restoration and find that pocket, I would have brought the patient back for further treatment and potentially finished the treatment if we never removed that restoration. However, now we're looking at that and saying that it has a very poor prognosis and should be extracted. So it's a very important part of the process. When we come to New Zealand and run the courses, we will go much further into this. We'll go through the whole process for access, and we'll show that we can be very conservative by removing tooth structure strategically. We can be very conservative in the important areas of the tooth, the pericervical parts of the tooth, and still have very, very good vision and access. And with our newer instruments, our more flexible instruments, like the ones that are Lurocell, the DC tape, or the E3 Conserve, we have instruments now that are much better able to complete the job of endodontic preparation without removing so much coronal tooth structure in that pericervical area, and are able to much better handle curved roots and are less likely to fracture. So we'll go into much more detail with that. We'll do a lot more practice. It's one of my favorite things to do, is to come and do courses and then see some of the work that some of our students can push out for us. People send me x-rays and it blows me away, the sort of work that they're doing after coming to our courses. So I might finish up there. We're just over time a little bit there. So if there's any questions, please send them through.
Thank you, Patty. If you have any questions, please put it on the chat, and we'll pass it on to Patrick. But I do have a question. So, obviously you've been doing this for a long time.
Yeah.
And I mean, as a specialist and also training. But if I'm just a dentist GP who is learn to do endo at dental school, I do their old cases here and there, but I'm really would like to learn how to be more conserved. How hard is to convert, to adapt to the techniques? Because what I understand is at dental school they don't get trained on these conserved practices. So how is that? How hard is to get the new techniques on board?
It's really not. I mean, you just need to. There's some small changes in technique that need to be taken into account. The files do act a little bit differently, because when the newer instruments, they're heat treated most of the time. So the nickel titanium is sort of heated up, cooled down, and they become much more flexible, much more resistant to cyclic fatigue, which means you can put them around much sharper bends and rotate them for much longer before they separate. But they also become a little bit, they're not as hard, so it's a softer metal. They don't cut as aggressively. And so there are some changes in your techniques that need to occur, and that mostly is you actually have to spend a bit more time in the canals with the instruments for them to cut enough of the tooth structure so that you can move on to the next instrument. It's a much more gentle and comfortable procedure actually than it was with the older style of instruments that would cut very aggressively and weren't as flexible. Because with those instruments, you really wanted to get down, get to length, and then get out. You didn't want to leave them there because they would straighten and they would remove a lot of tooth structure and they might break. Whereas with the new instruments, you actually spend quite a lot of time. So there's a little bit of practice in there, and you really ideally would get extracted teeth and practice so that you can get the feel of the instrument and learn and actually learn to trust that you can spend time in the canals with these instruments. The other change is that one cost of being more conservative is that these files follow the path of the canal so much better than the older files. The older files used to just expand and rip and straighten. And these, when you're more conservative, when you use instruments, it means that the preps are smaller and they follow the path of the canals. And so the GP that is produced doesn't, you need to just take a little bit more, be a bit more accurate in the way you manage your GP. And it's not a difficult thing. The obturations become pretty straightforward after a little while. But there's a little bit of technique in that we need to teach as well. So always, just coming along to the courses and, as much as possible, or even just asking people who are using the instruments how they work. I see Tony there. Tony, hi, mate. Tony did our course. When was that, Tony?
2019.
2019. Yeah. So just before COVID, so Tony did our course there, and he's been using conservative instruments, and some of the cases that he puts out are amazing, just amazing in terms of how conservative they are and how well they're performed. And it's a bit of a learning curve, but if you want to improve things, and you should want to improve things, like you see, you want to improve your aesthetics and you want to make sure your crown preps are all nice and smooth. This is something that we should improve, because it's something that there is generally a lot of improvement to be had in. So like anything, you can't just, you're not going to start, doing anterior composites like Tony Rotondo all of a sudden. You've got to practice and you've got to spend time. And the same thing is with endodontics. If you want to get better at it, you got to practice and spend time with it.
Cool. Awesome. That's right. Well, I don't know if anybody has any questions. I haven't seen anything on the chat. But I hope that everybody who is in the webinar and everybody else who sees the recording, because we do record this and send it, as we have a little section on our website that it has all the DENTACHATs.
Yep. Okay.
So Patrick, if you finish your sharing screen, will be
okay. Hang on. I'll do
good.
that.
I'll do it. Thanks.
Is that it?
Yeah. Well, thank you so much, Patrick, for spending an hour with us. That's good.
Pleasure.
As I'm talking to you, I can hear the hail blustering through the window.
Oh no. Okay.
So well, you're probably sitting on 22 degrees.
Yeah.
In a sunny day, and then you wonder why people move there, right?
Yes. There are a lot of New Zealanders over here, that's for sure.
That's good. That's good. Anyway, look, we're looking forward to host you over here in Auckland next year and get some hands-on with dentists onto it, into the Conserve techniques. But thank you so much for your presentation. It was really good. And thank you everybody who joined us. As I say, we keep doing these DENTACHATs with different topics. So watch out for the next DENTACHAT. But until now, have a good night.
Okay. Thanks everyone.
Thank you, Pat.
Bye-bye.